Okay, so thank you very much again for the very kind introduction. It's a great pleasure being here, and I'm also impressed by the diversity of the program, and I think it's very important that we have to bring different disciplines together. Even, let's say, policy, advocacy for general things, they have to understand what are the problems of HCV, and the basic scientists, they have to understand why actually we're doing this work and why is it still important. Tomorrow I will speak on hepatitis D and E. Today I will speak a little about our translational research, also in the context of HCV therapies. We had a great session this morning introducing to you already treatment trials and then translational research investigating different immune cells. Many people are doing this one. We also have some programs ongoing, and I'm going to present to you some of this work. And main part of the work that I will present to you in our group that I'm running together, or have been running together with Markus Kornberg, has been done by Julia Hengst. She is now a postdoc in the group. She graduated last year, and she did really an excellent job in collaboration, in particular with our colleagues from the Karolinska Institute in Stockholm. Hans-Gustav Lundgren and Niklas Björkström were really instrumental into many of the data that I will show you in a minute. This morning we discussed already, and we all agree, and there are some basic concepts that HCV causes obviously liver inflammation. And we also discussed this morning that this is important beyond the liver. That's 1/3 of the blood volume is passing the liver every single minute, which we have discussed. So this may have broader consequences. And therefore, liver disease may affect systemic immune responses beyond the HCV-specific immune responses. This is the background. Obviously, then leading to the consequence that HCV infection is not only a liver disease. We have a variety of extrahepatic manifestations, and there have been data, which we also discussed yesterday, that HCV increases the risk of dying from non-hepatic diseases. This is quite clear, and with which we have to keep in mind also with the discussion in some countries whether to treat only F0, F1 patients. We have really to acknowledge this is an infectious disease. It's not only a liver disease. The good news is, and this has been discussed during this meeting and throughout, let's say, the last 2, 3, 4 years, that HCV cure improves liver function and reduces the risk to develop clinical events. This has been shown, and there are, let's say, every week there are new papers published from different cohorts showing that you have a lower risk for developing hepatic decompensation, and that in the long term also HCC probably the risk is declining. And however, what we have to keep in mind also when using clinical samples for translational research is that there is a different dynamic in the decline of this systemic inflammation. If you very simply look into FibroScan values, liver stiffness, you have seen many of these data, and maybe some of you have own experience that liver stiffness values, FibroScan values decline if you compare a pre-treatment value, for example, in this case with a follow-up 24-week measurement of liver stiffness. But if you have a closer detail or a closer look into details over time, and in this context, you see that this dynamic. You have an early, more rapid decline of liver stiffness values, and then a slower and some long-term decline, maybe even a plateau in the long term. And this needs to be considered also, for example, this morning when we discussed at which time point you do the translational investigation, whether you talk about day 7, day 14, or week 96 investigation of your respective translational readout. So then why it is important at all to understand how HCV clearance influences immune responses? I don't want to repeat all the arguments we were discussing this morning, but I think it's really important that we talk about these infectious diseases which may have roles for extrahepatic manifestations, and also maybe this aging concept, inflammation leads to aging. And I think we can understand from HCV a lot also which may be important for other infectious diseases and other diseases in general. So then how to address this point, the interaction between HCV and immune responses? We discussed again this morning that HCV-specific T-cell responses may be restored in certain settings. maybe this has consequences for re-exposure to be investigated. But we have to talk about other immune cells. There are T cells specific for various other pathogens. We discussed CMV. I will show you some data on EBV. And the question is really, how does HCV clearance affect the other immune responses to other pathogens? And Lisa mentioned this morning, it's quite interesting to see how do HCV patients respond to flu vaccination, to HPV vaccination, and what is the outcome here. And then we have other immune cells. I will show you some data on NK cells. NK cell is not one population. You may have different subgroups, and the effects of HCV clearance may be different depending on which subgroup of NK cells you look. And if you are then not exhausted yet, you can look at various other immune cell populations, and there's a huge playground where you can promote students and academic careers looking at each single of these cell types. So what was our approach? We have been looking to many of these cells, and hopefully you are now fit. I will show you data on all these immune cells. So soluble markers, different immune cells, this works for some students, but this should only give you a hint that HCV matters for different immune cells, for different diseases. And I think we have to have a global view on the immune system to really understand for which part it may matter to get rid of HCV, and for others it may not, it may have not major consequences. If you then have a look simply as the cytokine milieu in the blood of HCV-infected patients, in this case, we measured 50 soluble inflammatory markers, chemokines, cytokines, growth factors. You can see it's a very simple thing, as to be expected. HCV patients look different as compared to healthy controls, but also, and this is important, different to patients with another non-viral inflammatory liver disease, so in this case, fatty liver disease. So the liver is inflamed in these NASH patients, but HCV patients have a different profile of altered immune responses. And what is altered? Then you have to go into each marker individually, and you can see here that some markers are upregulated in the blood of HCV parameters, while others are downregulated. So, and there we have to have a close look, and the recovery in the long term may differ between single markers upregulated versus other markers being downregulated. And if you then treat HCV, it's very important that at least during this follow-up of 24 weeks after the end of therapy, these markers do not reach normal levels. Some markers do, for example, IL-12 almost normalizes, but IL-18 declined, IP-10 declines. But even in these patients that have been HCV RNA negative for an average 36 weeks, you still have elevated levels as compared to a healthy population. But what I think is more striking, those parameters showing in the lower part of the slides, which were lower than healthy controls, they did not recover at all. You can see they stay at the lower level, so suppressed markers did not recover. And then when looking at each of these markers individually, this is also what we discussed this morning, which of these markers are driven by HCV infection and which are simply driven by liver disease. And there are obviously some items which show correlations, which are driven rather by cirrhosis, by inflammation of the liver, than by HCV infection. So we have to have a closer look into each of these markers and then to understand what does it mean in the long term for each individual. So let's have a look as to some of these individual cells. HCV-specific T-cell responses. Georg showed you very nice data this morning with a lot of parameters. He also mentioned, however, that function is critical. One of our students is also addressing this, but the challenge when talking about HCV-specific immune responses is that even in, let's say, untreated patients, you have an extreme diversity of immune responses. We talked this morning about PD-1. You know that blocking checkpoint inhibitors is a treatment in various cancers meanwhile. But if you in vitro expose HCV-specific T cells with checkpoint inhibiting antibodies, you can see that there's an enormous diversity of responsiveness to the cell. You may have one patient which has a nice restoration of T cell responses in vitro by PD-1 blocking, while other patients, you don't achieve anything. You may need to throw all checkpoint inhibitors at the same time to restore some immune responses in vitro, which is a problem. And then obviously there are various other factors which may influence this responsiveness of these T cells. For example, very simply age. So the older a patient is, the higher likelihood is that he is not responding in vitro to peptide stimulation, that the cells expand. There you may need in addition multiple blockade strategies, or you may be even not able at all to restore T cell responses in vitro. And in this context, that we have an enormous variability of immune responses already in different patients, then obviously it's logical that not every patient is also responding in a similar way when you treat these patients with DAA, when you get rid of HCV infections. So for example, in this case, very well in line with the data we saw this morning from Georg and Lisa. Also in our case, T cell activation or the activation markers are reduced by HCV clearance, while exhaustion markers pretty much stay the same, which is absolutely in line, 100% what Georg showed this morning. We have some functional data which are shown on the right side. We see some increase in proliferation of these cells, but in many patients we do not see an increase. Again, an enormous diversity in responsiveness. And then talking about the idea, which we also discussed this morning, of vaccinating these patients. You may appreciate when you look onto the responsiveness of these patients on the right side, this huge spread of responsive, that some patients may respond very well, for example, to vaccination, while others will not respond at all. So it's very unlikely that we will have one super vaccine in the future that will cause a broad response in every patient leading to protective immunity. It's very unlikely. We discussed also this morning again that HCV infection may affect other immune cells. We had a closer look to CMV and EBV specific CD8 T cells. Very simply, if you look at numbers in HCV infected patients, we found higher frequencies of both CMV and EBV specific CD8 T cells. These cells had higher levels, probably in the context of activation of this inflammatory milieu, of activation markers, not necessarily meaning exhaustion in this stage, of PD-1 and TIM3 and also 2B4. And then if you cure HCV, that some of these markers decline. However, in vitro, and I did not or cannot show you the data for time reasons in detail, we did not really see a major change in function of these CMV and EBV specific T cells before and after HCV cure. What is important then, this was virus-specific T cells. What about HCC-specific T cells? We all know that patients with liver cirrhosis have a risk to develop cancer, which is really high. And there has been this debate that HCCs may still occur despite HCV clearance. And this is also our experience. This is data from the Hannover Medical School HCV cirrhosis cohort. And you can see, and then with all the discussion about maybe an increased risk even for HCCs in DAA-treated patients, the problem is always the controls. As all patients cure HCV infection, you don't have a control like in the old times of interferon responder versus non-responder. So it's quite hard to have the appropriate control group in this context. What we try to do, we use a historical control of patients seen with pretty much the same patient characteristics, treated at the same site with the same HCC surveillance system, which I think is also very important. And there you can see that in the short term, we could not see any difference at all. In the long term, this did not reach statistical significance yet, but it looks that after 1.5 to 2 years, you may see less cancers in HCV treated patients. But still, HCCs occur. And therefore, the question is whether HCC immune surveillance is altered or affected by HCV treatment. And therefore, another fellow in the lab looked for immune responses against a tumor antigen, so GPC3. So you stimulated cells from HCV patient with these peptides, which presumably could mirror an HCC-specific CD8 T cell response. You can see here that you can get nice cytokine responses. You also has data for tetramer specific for some of these antigens. And then when you when you pool this and analyze the data, I was really shocked how frequent these responses were in patients with cirrhosis who did not have detectable cancers at that time point. So basically, every cirrhotic patient mounted a rather strong T-cell response. I didn't expect this at all. And some people ask me, what is the explanation? Is it that every cirrhotic patient has a little cancer, which is controlled by these immune responses, which would be rather provocative, or just this increased cell turnover leads to this rather strong responses? It's interesting. The point then is, however, what is happening if you cure HCV? Do you affect these immune responses shown on the right side of each graph? And yes, maybe in some patients you see a decline of these HCC-specific T cells, both in terms of function as well as in terms of frequency. Whether this is a correlate for single patients that they may be at higher risk to develop cancers to be shown is very hard to show in detail, but we have to keep in mind something is happening, and if this is taking place in the wrong patient at the wrong time point, it may contribute to cancer development, but this remains speculative. Then there are various other immune cells which may have importance in distinct settings, not necessary for HCV, but maybe also for HCV. But if a patient has, for example, fatty liver disease, if he is experiencing additional infections, then these other cell types may also contribute to disease pathogenesis and maybe to the risk to develop clinical complications. And I just want to give you now a snapshot to one of these cells. One is mucosa-associated invariant T cells. If you compare HCV patients with healthy controls and just look at numbers, you can see here that the MACE cells are basically wiped out in chronic HCV infection, which is similar to HIV infection, where you also lose these cells. These cells have, you see here, the reduced frequency as compared to healthy controls. What is happening if you cure HCV? Nothing is happening. These cells do not come back at all, despite HCV cure, which again is in line with HIV infection also. If you put an HIV positive patient on heart, these cells do not recover in the short term. At least we need to have longer follow-up. And I skipped the functional data. You can see on the lower part that, for example, TNF production, interferon gamma production, or activation markers do not recover despite HCV cure. NK cells, we have also a nice project together with the Karolinska group. Overall, in our hands, if we compare HCV and patients and healthy controls in terms of NK cell phenotypes, we also did here a 20 parameter analysis of different markers on the surface and function of NK cells. And these are the SNE plots that also Georg showed you this morning. We do not see dramatic differences in NK cell populations between healthy controls and HCV. You can have a closer look at each of these markers. There are some changes. If you then, however, look into more detail, it's quite interesting that NK cells are different, not on a single level of each markers, but in terms of diversity. This is quite interesting. If you compare different HCV patients, you can see here, if you would compare the blue and the red lines, the mean and median values would be similar, but you can see it's more spreading. And this is basically this inter-individual variability. And if we compare this between HCV patients and healthy controls, you can see here that this DEV was much larger. If you then, on the other hand, look into intra-individual variabilities, which meaning in some patients, one population may expand, while in other populations may expand, you have reduced diversity in HCV infected patients. And if you then look over time, this altered imprints of HCV on NK cell diversity and donor to donor variation is not altered at all if you take away HCV, which I think is also quite interesting how stable this is. And very lastly, very shortly, I promised you one slide on gamma delta T cells, which we just analyzed. So we did a next generation sequencing of the delta repertoires in D gamma 9 positive and negative cells. This is more detailed. We also see some alteration in HCV, but no major changes over time, which is again is in line with the MAIL data and is again in line with the data I showed you also for NK cells. So this is basically already what I wanted to show you. It's overall, I think what we have seen, HCV cure has imprints on HCV-specific T cells, on some of the innate immune cell population. What we need is now longer follow-up. We really need to show what is happening after 2, 3, 4, 5 years. We need to follow our patients, and also for you not doing immunology, but who are treating patients, call back your patients even if they are F0, F1, F2. I think we need to understand what is going on. For me, it's too early to send the patients home and saying everything is fine. Thank you very much.